Good morning, everybody, and thank you very much for joining us here today on this very exciting hour of exploring some of the discovery that is occurring within the Department of Pediatric Newborn Medicine. We literally have been born here at the Brigham in the last 2 years, and so we're very proud to present just a sprinkling of the type of research activities that are going on in the department. We've focused it around building a better brain, improving outcomes in high-risk infants. It's important to put this in the context of the Brigham's history, and it's a very deep and long history. In fact, in 1832, the Massachusetts Charitable Fire Society and the Humane Society each contributed $5,000 towards establishing a hospital for the care and relief of poor and deserving women. This was founded by Doctors Channing and Hale, and this was the foundations of the Boston Lying-In Hospital. In 1923, many of you are familiar with the Longwood Avenue site, which was the new home of the Boston Lying-In. And in 1975, a merger occurred between the Peter Bent Brigham and the Robert Breck Brigham, with a move here to the premises in 1980. So our history is long and deep, and we're proud of it. When you look back, this is what the Lying-In looked like. Those little cars aren't Tinker Toy cars. They really are the way it looked then when they pulled up. And this is the way our babies were cared for at that time in the Lying-In. Parents weren't allowed to come and see their babies because of the risk of infection. And so the nurses took, as they do now, a very important role in nurturing and caring. And you can see all these little babies being bottle fed by the nurses. Here's the babies in the Lying-In, all lined up as they're being cared for. And here's a baby receiving a gavage feed, the old-fashioned orogastric feed. So we're proud of our history, and we want to take it forward from our team now, Steve Ringer, Lisa Johnson, Joe Allen, all people who have been here for many, many years leading our team into life-starting and life-giving breakthroughs. But today we're going to focus on different types of risk to the developing brain. We've got the pleasure of having 3 of the department speak briefly on their areas of interest, and I will close with some comments around high-risk term-born infants and high-risk prematurely born infants. But it's with that I have pleasure to introduce Dr. Sen, Dr. Ortinau and Dr. McPherson, who will be covering topics on risk of brain development during pregnancy, the power of MR imaging in defining altered brain development, and the impact of pain and pain medications on the immature brain. So without further ado, I have the pleasure of introducing Remy Sen, who is a neonatal attending at in our department, and she will launch straight into her area of expertise, which is the risk for brain development during pregnancy.
Thank you, Dr. Inder, and thank you for inviting me to present my research to you today. As all of you know, obesity has been called the most pressing public health issue of our times. As the CDC map illustrates, in the last 25 years, there's been a tripling of obesity rates in the US. And currently, over 1 in 3 US adults is obese with a body mass index greater than 30 kilograms per meter squared. Women of childbearing age have also been a part of this trend. And this data from the state of Maine shows that between 1981 and 2005, the average early second trimester weight has increased by over 20 pounds. As women have entered pregnancy at higher weights, this has had effects on pregnancy health as well as peripartum health. In neonates, we have seen higher rates of prematurity in infants born to obese women, likely due to increased rates of medically indicated preterm deliveries. These infants are also at higher risk for birth defects, specifically 3 types of birth defects: rates of congenital heart disease, rates of abdominal wall defects, and rates of neural tube defects are all significantly increased in infants born to obese mothers. Both of these, prematurity and birth defects, can have lifelong implications on offspring health. As these children age, they're more likely to be diagnosed with asthma, allergic, and atopic diseases, and more likely to be obese themselves when they are children and adults, thus perpetuating this cycle. There's a recent body of literature that has also linked maternal obesity to developmental, learning, and intellectual disabilities in offspring, including autism spectrum disorders. Throughout the life cycle, obesity is associated with an abnormal metabolic environment, characterized by inflammation and oxidative stress. Other investigators are doing remarkable work in primary treatment and prevention of obesity in childhood and also in adulthood. My perspective as a neonatologist affords me the opportunity to investigate the critical time period between conception and early infancy. This is the time period that I believe sets the foundation for lifelong offspring health. The goal of my research is to understand the metabolic dysregulation associated with maternal obesity from conception through pregnancy and early infancy, and to devise interventions to improve this metabolic environment. To understand the effects of obesity during pregnancy on the metabolic environment, we investigated the relationship between maternal body mass index and markers of inflammation and oxidative stress. We measured C-reactive protein, a marker of inflammation, in obese and lean pregnant women in between 22 and 26 weeks of pregnancy. We found that as maternal body mass index increased on the x-axis, C-reactive protein increased on the y-axis. And a similar trend was observed with glutathione, which is a marker of oxidative stress. At the same time, and in the same cohort of women, we also measured concentrations of primary nutritional antioxidants. We found that as maternal body mass index increased, once again on the x-axis, concentrations of vitamin E, vitamin B6, red blood cell folate, and vitamin C were significantly lower in women of higher BMI. Taken together with research I'd conducted during my fellowship in an animal model, which showed that offspring of dams who were fed a antioxidant supplementation had improved outcomes, we embarked on the prenatal vitamin study. Currently, all women, regardless of their pre-pregnancy weight, are recommended to take the same prenatal vitamin. The goal of our study is to understand whether supplementation of obese pregnant women with increased amounts of antioxidant vitamins will improve the metabolic environment during pregnancy. With the help of our obstetric colleagues here and at the BI, we're conducting a double-blind randomized control trial of 100 obese women early in pregnancy and 100 obese women planning pregnancy. Women are randomized to either a control group where they receive a standard prenatal vitamin that we've provided with a placebo, or the intervention group where they receive a standard prenatal vitamin with a supplement of vitamin B6, C, E, and folate. Our primary outcomes are vitamin levels and markers of oxidative stress and inflammation in mothers and infants, and our secondary outcomes are maternal and neonatal clinical outcomes, infant growth and adiposity, placental histopathology, breast milk composition, and infant neurodevelopment. And we are about halfway through recruitment for this study currently. As I'd mentioned before, we're also interested in the impact of maternal obesity and maternal metabolic status on postnatal health of the infant, specifically through breast milk. Petula Panagos, who's a neonatal fellow, measured levels of pro-inflammatory nutritional substances in breast milk in obese and lean pregnant women 1 to 2 months postpartum. What we found was that as maternal BMI increased on the x-axis, the ratio of omega-6 to omega-3 fatty acids, which is a pro-inflammatory ratio, increased in breast milk. We also were interested in the contribution of maternal dietary inflammation on breast milk composition and found that as maternal dietary inflammation increased as measured by the dietary inflammatory index on the x-axis, saturated fatty acids, which are also a pro-inflammatory substance, were increased in breast milk. As DII increased, the dietary inflammation increased, monounsaturated fatty acids, which are anti-inflammatory, were actually decreased in breast milk, suggesting that both increased body mass index and increased dietary inflammation contribute to pro-inflammatory breast milk. In this same study, we also found that concentrations of neuroprotective substances, DHA, ARA, and lutein, were significantly lower in the breast milk of obese compared to lean postpartum women. Using this study as the basis for some upcoming research, we hope to design 2 follow-up studies to understand whether maternal postnatal nutrition supplementation can improve breast milk composition in obese mothers, and also whether we can target dietary modifications, such as decreasing dietary inflammation, to improve the metabolic environment of obese pregnant women. And of course, our long-term and overall goal is to understand whether decreasing inflammation pre- and postnatally can improve outcomes in infants born to obese mothers. And with that, I would like to acknowledge my mentors, Petula and Chitra, who were 2 of the fellows who worked with me on projects, Dr. McElrath from obstetrics here, as well as my funding sources. Thank you.
Thank you very much. And we'll be holding a panel discussion at the end of each of the presentations. And without further ado, I'd like to introduce Dr. Cynthia Ortinau, who is also a neonatal attending in the Neonatal Intensive Care Unit, who has been studying the insights from brain imaging in infants with congenital heart disease.
Okay, thank you very much. It's a pleasure to be here today to talk about some of the work that we're doing in congenital heart disease. So I did just want to start with talking about congenital heart disease and what that is. So this is a picture of a normal heart. You can see there are 2 sides, the right and the left side of the heart. The right side is responsible for pumping blood out to the lungs. The lungs oxygenate the blood, and that blood goes back to the left side of the heart. The left side of the heart is then responsible for pumping blood out to the body through the aorta, and that's how the body gets oxygen. So any abnormality that is affecting either the structure or the way blood flows through the heart is known as congenital heart disease. This is something that we know occurs in about 1% of all live births. And the group of congenital heart disease that we're particularly interested in focusing on are those that are called moderate to severe lesions. They make up about 1/4 of all of congenital heart disease, and these are lesions that result oftentimes in need for neonatal surgery and critical illness in the newborn period. Now, over the last several decades, there's been a dramatic improvement in survival of these children, so much so that adults now outnumber children with this diagnosis. So there are now 60% of the population with congenital heart disease are adults, whereas 40% are children. And it's become very evident that long-term complications are an important focus for study in this patient population. What we know is the most common adverse outcome in these patients is neurodevelopmental impairment. And this is a graph showing the severity of the congenital heart defect on the x-axis with a percentage of impairment on the y-axis. And you can see that as the severity of the defect increases, the likelihood of neurodevelopmental impairment increases as well. So what we would like to do is be able to improve these neurodevelopmental outcomes. And so in order for us to be able to do that, we have to understand what's happening in the brain itself. What we know about these children is that they do have high risk of brain injury. And these are pictures here representing a type of injury that we see called white matter injury. So you can see these dark spots here on the diffusion imaging, and then dark spots here on the anatomical images as well. This is what we call white matter injury. And what's interesting about this is a pattern of injury that is very similar to what we see in preterm babies. Now, it's not surprising to us that injury exists in these kids, certainly because they're undergoing cardiopulmonary bypass, they're critically ill, and so we expected to see at least some form of injury postoperatively. But what's particularly interesting is that even before cardiac surgery, these kids have injury. And so that led to the idea that there's probably something else happening in these babies' brains. And what we now know is that these children have abnormal brain development. This is one of the patients in one of our studies from St. Louis. This baby had a diagnosis of hypoplastic left heart syndrome, which is one of the most severe forms of congenital heart disease. This is an image of a fetal MRI at 31 weeks gestation, and you can see the outside part of the brain here. The cortex is the dark area. The white matter is this lighter gray area, and here are the fluid spaces within the brain. Now, even for 31 weeks, this looks a little bit delayed in development, but you can certainly see after birth, by 2 months of age, there's a large amount of increased space around the brain, decreased volume of the brain tissue itself, the fluid spaces are enlarged, there's a small little area of injury here, and then certainly by 3 months of age, this continues to progress. So what we were particularly interested in looking at is what's happening before cardiac surgery in the way of brain development. So we looked at a subset of patients. There were 67 patients enrolled in this study where we looked at brain size before cardiac surgery. We just did simple measurements across multiple different regions of the brain. And what we were able to demonstrate is that children with congenital heart disease in the newborn period within the first week of life before they even undergo cardiac surgery have abnormalities in their brain size, so smaller brain volumes across multiple different regions within the front part of the brain, the middle part, the cerebellum, which is towards the back part of the brain here, as well as the brain stem. And it's actually not just alterations in brain size. What we're also able to do with the MRIs is create these three-dimensional reconstructions where we can look at the surface area of the brain and we can look at how the brain is folding as it develops. And what we were able to show is that the children with congenital heart disease, even before cardiac surgery, had smaller surface areas of the brain and less folding of their brain as well. And when we look at the regions that are affected, you can see multiple areas popping out. So this region here is near the motor areas. This is near the visual spatial areas. This region is connected with behavioral and attentional networks. And so these are things that we know these children are at risk for adverse outcomes in. And so this may be providing us some indication as to what's going on in the way of long-term neurodevelopment. So these are certainly all things that are present even before cardiac surgery, and that led to the idea that perhaps these are evolving even before the babies are born. And these are data actually from here out of Boston from 5 years ago, looking at brain MRI and fetuses with congenital heart disease. And you can see as you progress through the third trimester of pregnancy, fetuses with congenital heart disease have a smaller total brain volume than healthy control fetuses. And so our prior work, as well as these data from fetal MRI, have stemmed some of the questions that we have really honed in and focused on. So the gaps in knowledge that we have at this point is understanding the exact timing of onset that these alterations are occurring during the period of fetal brain development, what the trajectory is of brain growth, and particularly development of the cortex, or the outside part of the brain, what specific tissues or regions are involved, because that will help us identify and link structure to function. What are the high-risk diagnoses? So in the literature, in the outcomes literature, it suggested that hypoplastic left heart syndrome is particularly at risk, but are there other diagnoses that we're seeing in utero as high-risk diagnoses? And certainly, what are the implications of genetics in the way that the brain is forming and developing in these children? And these are really critical questions for us to be able to answer before we can identify and optimize ways to protect the brains of these babies. So that leads me to our fetal cardiac brain study here. And I did just want to mention the design of this study. We don't have results yet. We're about halfway through recruitment. But what we're doing now in collaboration with here at Brigham with Boston Children's is recruiting 120 pregnant women with and without fetal congenital heart disease. They're undergoing serial MRIs, so they get MRIs twice during the pregnancy where we're looking at the brains of their babies. And we're able to apply a variety of different techniques to characterize brain growth and development in the fetal period. So one technique that we do, this is something called volumetric analysis, where we can segment out different structures and tissue types of the brain so that we can calculate the volume of the outside portion here, the cortex, the white matter, some of the deep gray structures of the brain, and the fluid spaces. And we can look at how this changes over time during the pregnancy. We can also do similar three-dimensional reconstructions as what I showed you in the previous slide so that we can look at cortical surface area and brain folding and how those change over time as well. And we'll be investigating this in association with a variety of different factors, specifically cardiac physiology, so their diagnosis, but also looking at the ultrasound of the heart to see if there are measures on their heart ultrasound that predict the way their brain is growing and developing, sociodemographic factors, clinical factors related to the pregnancy, as well as genetic factors. So hopefully in the next year and a half, we'll have all of our patients recruited for that and have some preliminary results to show. So with that, I'd like to just acknowledge all of the folks who have been involved in all of this work. Terrie Inder in particular, who's my primary mentor. Jane Newberger is my mentor at Boston Children's. And Caitlin Rollins and Ali Ghalipur are co-investigators on the fetal study here. Thank you.
Thank you very much. And now for our third presentation, it's my pleasure to introduce another member of our faculty, who is Dr. Chris McPherson, who has a role in leading and guiding a lot of our pharmacological management of our high-risk infants within the Neonatal Intensive Care Unit, and has published and has a particular interest in the impact of pain and pain medications on brain outcomes.
Thanks so much for this opportunity. So, as Terrie said, I'll be speaking about drugs in the neonatal brain and more specifically pain medications in the neonatal brain. It's really impossible to summarize the work of Dr. Inder's entire career in one slide, but if there is one slide that summarizes that work, it might be this slide. And this will be the focus of my ideas and my research. So you can see the 25-week neonatal brain. These are the youngest, most viable neonates that we take care of in the Neonatal Intensive Care Unit. It's a very smooth, underdeveloped brain. And over the course of their NICU stay, you can see tremendous development. And the term equivalent brain, when they're discharged from the NICU, looks actually a lot like the adult brain. There's so much that goes on in the Neonatal Intensive Care Unit in terms of brain development. Unfortunately, this term equivalent brain of a baby born at 25 weeks doesn't look quite like a term control brain. So there's tremendous opportunity for those of us caring for babies in the Neonatal Intensive Care Unit to try to make this brain look a lot more like this brain so that our babies have improved neurodevelopmental outcomes at discharge from the Neonatal Intensive Care Unit as well as throughout their lives. So specifically, I'll be focusing on the problem of pain. And we know that premature neonates feel pain. Actually, premature neonates feel pain more dramatically than any other population in the hospital. They have mature ascending pathways that carry the pain signal from their bodies to their brain. However, they have immature descending pathways that can localize and mitigate that pain. So this problem is not only important in premature neonates because of brain development, but it's important in premature neonates from an ethical perspective because they are our most vulnerable population when it comes to this problem. We know definitively that chronic pain and agitation worsens outcome, and that's work that's been done on the other side of the country in Vancouver, not this country, but in Canada, in Vancouver. And just tremendous work showing that increased pain in the neonatal intensive care unit alters outcomes at 2 years, 4 years, 6 years of age, and changes the behavior, the cognitive ability of these babies into childhood and even early adolescence. So as a pharmacist, I want to treat this problem. I want to give pharmacotherapy that can improve long-term outcome. And the reason the line becomes dotted at this point is because drugs that have been currently studied to this point don't necessarily improve long-term outcome. So I'll summarize some of that data. I'll share with you our contributions to that data, and then I'll hopefully give you guys an idea of what we're interested in studying as a pharmacotherapeutic intervention that could possibly treat pain but also improve the long-term outcomes of these vulnerable babies. Why does pharmacotherapy help? Pharmacotherapy could potentially help, and I highlight this example with the most common drug used in the neonatal intensive care unit for this problem, opioid medications. Opioids in the acute setting, they reduce neuronal metabolic rate, they reduce excitotoxicity, they reduce neuronal injury. In the acute setting, these drugs have a very positive impact on the pain and stress that neonates are encountering during neonatal intensive care. However, when we look at studies of these drugs, specifically in relation to acute brain injury, unfortunately in randomized controlled trials, morphine increases the rate of poor neurologic outcome. It increases the incidence of brain injury, intraventricular hemorrhage, as well as periventricular leukomalacia. It also increases the risk of death, so not a therapy that we're excited about giving in a large quantity to our babies. And these studies have long-term neurodevelopmental follow-up as well. And unfortunately, the story gets worse when you look at long-term neurodevelopment. And mechanistically, it's a very interesting phenomenon why these babies do worse when they're exposed to morphine, an agent that we hope would be helpful. Unfortunately, prolonged exposure to opioids leads to tolerance, which causes phosphorylation of, this is a neuronal cell, so phosphorylation of the mu-opioid receptor that's carrying the action of that opioid to the neonatal brain, causes uncoupling of the G protein, the site of action, and coupling with a negative protein called beta-arrestin, which can decrease the rate of cell cycle progression, so decrease brain growth, as well as increase cell death. Both dramatically negative effects on that rapidly developing brain in the neonatal intensive care unit. On this basis, the American Academy of Pediatrics wisely says that continuous infusions of these medications, morphine and fentanyl, both opioids, should not be used in chronically ventilated preterm neonates. However, we're compassionate caregivers, and we use these drugs commonly in practice despite these recommendations from the AAP, and it's basically because we don't have alternatives at this point. So my early career work was leveraging that opportunity, that open label use of both morphine and fentanyl in the Neonatal Intensive Care Unit to try to expand on the knowledge we have of the impacts of those drugs on the developing brain, and also to explore potential ways we can look at alternative agents that may be better for the brain. To do this, we use term equivalent MRI, which Cindy has already shown you a lot about the many outcome measures we can look at with term equivalent MRI, and we use that as a surrogate marker for long-term outcome. It's a measure that we can get when the babies are discharged from the NICU, but we can use it to estimate or guess what the outcome will be further down the road without having to wait 8 years to find out what the outcomes are the children that are being cared for in the NICU. The initial cohort we looked at was recruited at the Royal Women's Hospital in Melbourne, Australia. And you can see in this study that was published in Journal of Pediatrics, we compared babies that received low-dose morphine to those that received no morphine. As compared to the randomized clinical trials, the doses of morphine used in this trial were very conservative. They were dramatically lower than that of the randomized control trials in the hope that less exposure to this potentially harmful agent would be less harmful to the babies. We looked at brain injury in these babies, so periventricular leukomalacia, intraventricular hemorrhage, as well as cerebellar hemorrhage, shown examples on the term equivalent MRI. And you can see there was no difference in the incidence of these brain injury markers in low-dose morphine exposed babies compared to those who received no morphine. We also looked at volumetrics, which Cindy showed you an example of earlier in the term equivalent MRIs, and you can see no difference in any region of the brain based on exposure to morphine. Additionally, this cohort was followed up at 7 years, where we used similar volumetric techniques to look at their brains at 7 years, and again, you can see no impact on the brain at 7 years, so long-term MRI outcomes showing minimal impact of this low-dose morphine. And finally, we looked at development of the cohort at 7 years, and again, you can see no impact of the low-dose morphine on any developmental measure that was looked at 7 years. So reassuring data. We think we can get away with low-dose morphine in the NICU safely. Unfortunately, it really limits our ability to titrate this medication in the NICU, so it's not exactly a positive finding. At best, it's a null finding, and it gives us one agent that we think we can use safely as long as we use it conservatively. The opposite end of the spectrum is fentanyl. So fentanyl is a potent opioid that we use in relatively high doses in the Neonatal Intensive Care Unit. And the second study was looking at a cohort of babies at St. Louis Children's Hospital that were exposed to large doses of fentanyl in neonatal intensive care. And you can see, as compared to the babies who got low-dose morphine, these babies had a high incidence of the brain lesion of cerebellar hemorrhage that correlated with their exposure to fentanyl in the first 7 days of life. Additionally, they had dramatically smaller cerebellums, and this relationship was linear when it was correlated with the log of the fentanyl exposure during the neonatal intensive care unit. And this mechanistically lines up with what we thought we would find. Fentanyl has dramatic and potent actions in the cerebellum, and it has a demonstrated impact on brain growth. And seeing this manifest in babies being cared for in the neonatal intensive care unit is very discouraging. And it shows us that we should likely, we still have to treat neonatal pain, but we should likely steer towards safer, effective agents. So my career question is, what can we do to fill in this line with safe agents that effectively treat premature pain but don't impact long-term brain development, in the best case scenario, impacted in a positive way? The agent that I'm really interested in is an alpha-2 receptor agonist called dexmedetomidine. Dexmedetomidine acts more locally than opioids and has all the positive acute benefits of reduced neuronal metabolic rate, reduced excitotoxicity, and reduced neuronal injury. However, the action in the neuron with long-term exposure is the exact opposite. Instead of decreasing cell cycle progression, you get promotion of cell cycle progression, and you have no impact on cell death. So you don't increase cell death in the developing brain. This is the exact type of agent we'd like to use in the neonatal intensive care unit. The idea now is that we have to use all of the technologies that we have available, most specifically, in my case, term equivalent MRI, but also all the safety measures we take in the neonatal intensive care unit, as well as markers of acute brain injury and long-term follow-up to see if this agent is as promising as it appears in preclinical work, with the goal of trying to make this term equivalent brain after discharge from the NICU look a lot more like this term control brain that develops in utero, so that our patients can have optimal outcomes in early adolescence and as adults.
And with that, I will finish up by just moving through a couple of areas that haven't been touched on that are advances in our field of building a better brain. The first is that of therapeutic hypothermia, and this is an infant here who's resting on a cooling blanket, who is intubated for ventilatory support with EEG leads and was transported in with a very concerned father, obviously. So why do we offer whole body cooling? What do we do? This is an infant who is wrapped in the critical blanket, which is our method of offering therapeutic hypothermia. We offer this to term-born infants who are born needing resuscitation or are at risk of ischemic brain injury. We cool the body down, as you can see on the device, by servo control to 33.5 degrees within the first 6 hours of life, and the baby remains cooled on ice, literally, for 3 days before being rewarmed slowly over a 12 to 24-hour period. Does it work? It works dramatically. 8 randomised controlled trials, over 1,500 babies internationally randomised, between a 25 to 35% reduction in any adverse outcome. And in surviving infants, importantly, improved neurodevelopmental outcomes. So number needed to treat is 5. When we talk about treatment of things like adult hypertension to prevent 1 stroke, we're talking about treating 500 to 5,000 people to prevent 1 adverse outcome. In this treatment, we're talking about 5. It's been compared to the greatest advance in medical therapy since antibiotics. So how can we also protect the term-born brain? Well, we know time is brain, just like in stroke, and there's now data to suggest that if hypothermia is started under 3 hours after birth, there are better outcomes. So this has a prominent role for education of the community. What are the outborn centres doing when a baby comes out and needs help? We also know that we need to monitor with EEG all of our babies, because it's been clear from very careful studies that 90% of the time that newborns are having seizures, you can't tell. They don't jerk in the way that adults do because the brain isn't connected in the same way. So seizures are very common in the newborn period, and particularly in these infants, and we need full EEG monitoring to target the drugs to prevent the babies from having prolonged seizures. And finally, we need to undertake MRI scans of the brain on day 4 and day 10 to define the nature and extent of any brain injury, to give advice to the family, and to start rehabilitation if it is needed. And again, you'd be surprised that about 35% of babies born in the USA at the moment who are comatose or stuporose or have seizures are not getting the opportunity to have an MRI scan to define whether brain injury is present. What kinds of patterns of brain injury do we see? This is the so-called watershed injury. You can see these white, bright areas are the areas of injury in the newborn brain that lie between the anterior middle and posterior cerebral artery. These are like focal strokes, and these infants often go on to develop mild to moderate learning disabilities later in the school years. But we hope that with early intervention we can aid the family. We know that MR is very significantly valuable in terms of predicting outcome, and there's very few predictive tools that we have that have this degree of sensitivity, specificity, and positive predictive value. And importantly, this doesn't matter whether you were before the era of cooling or didn't have the opportunity to be cooled, or whether you received cooling therapy. The tool is equally valuable. And then finally, I'd like to touch on the advances in our understanding of the premature infant. As many of you know, we now care for infants born as early as 22 weeks gestation. The smallest infant I've ever cared for weighed 290 grams. Some of our infants are extremely small and their chances of survival are low. But if you're born at the moment weighing between 1 to 1.5 pounds, you have about a 75% chance of survival. The big challenge lies in how can that survival be without long-term challenges. So that's where our focus is. We want our parents to go home being able to face the least amount of challenges possible. Why is it so important? Because this timing of brain development is so dramatic, as has already been pointed out. You go from this very smooth brain to this extremely complex and folded system. And we can map that by mapping, as you see here in the blue, dark blue, the grey matter, the white matter and light blue, as you've heard from Cindy, the deep grey matter, brainstem and the cerebellum. And these are 25 babies who received serial MRIs, and they're kind of the brain growth curves, if you like. You're used to looking at weight curves, so this is kind of the brain growth curve. So the brain tissue is on the y-axis, and the postmenstrual age of the infant is on the x-axis, and each colour is one baby. And there's just two things I want you to note here. One is if you start small, like the green baby at the bottom, then you tend to stay small. So what happens before you get to the neonatal unit during pregnancy is also important. The other thing to note is look what happens around 34, 35 weeks. It kind of accelerates, like you're on one slope and then you sort of pivot and you accelerate up. What happens in the neonatal intensive care around 34, 35 weeks? Well, you're kind of a feeder and grower. You're kind of sitting in the corner. You know, we're not really paying as much attention anymore. Well, I think we're missing an opportunity, which is something we've paid a lot of attention to in the design of our new intensive care unit in terms of the environmental enrichment and the opportunities for optimal nutrition in this period. You've seen this slide from Chris. It is striking to look at changes in brain development. And in fact, we did this in St. Louis looking at a healthy term-born infant who was staring out at the neonatal intensive care unit when 5 of his friends were going home at term equivalent. And I joke that the young people don't get this anymore, but like in Sesame Street, which one of these is not like the other, right? I mean, you can tell, like, you know, if it was me, I know which one I'd want to take home and which one I would be worried about taking home. But there's something wrong here. And these are all babies without injury. They didn't have injury, right? But something has gone wrong in the sequence of brain development. And we can map that and compare that between 54 premature babies and term-born babies. And what lit up, literally outlined here in black, is the temporal lobe. So there's disturbances in temporal lobe development in babies born prematurely. Now you might say, well, you know, give them a chance. They need to just get out of the neonatal intensive care unit and get home with their families and they'll catch up. They'll be good as gold. So we looked at a group of prematurely born babies who were 7 years old and compared them with term-born controls. And you can see the same pattern. So what does this mean? This means what we do in the neonatal intensive care unit impacts this region of brain development. It doesn't recover, it persists. And it persists and has impact. So brain injury is unique in its form in premature infants. 10% of our babies will have significant brain injury, but more importantly now we need to focus on brain development. And the neonatal intensive care unit experience and exposures matter. A very interesting recent study was just presented at a meeting I was at from the group in Michigan who studied by video camera every time a premature infant in the neonatal intensive care unit was disturbed, and it was every 17 minutes. Every 17 minutes something was happening to that baby. Stress and sensory isolation appear to adversely affect brain structure and development, and I haven't had time to present that data. Nutrition is important and often impaired, and the period to term equivalency is critical in brain development, whether during pregnancy or whether during babies born early. So with that, I leave this image of what happens at the moment, despite our environmental constraints in our neonatal intensive care unit due to our remarkable team, and what we hope to continue the mission to optimise brain development in high-risk infants. Thank you.
I'm Dr. Malika Marshall. I am a physician at Mass General, and I'm the health reporter at WBZ News. And you might be wondering, what is a Mass General person doing at the Brigham, leading a panel? But I actually trained in internal medicine and pediatrics, and I did all of my medicine training here at the Brigham. I had all 3 of my babies here at the Brigham, and this is exactly why I chose the Brigham to have my babies, in case anything went wrong. So thank you for all the wonderful work you're doing. We don't have a lot of time left. We will be taking some questions from the audience, so if you can think of some things. I think I just want to start off by asking Dr. Inder. The research on cooling is fascinating, and I'm actually going to be talking to you all later today about doing a story on it. Is there any role of cooling in the preterm baby, and are there any things on the horizon to try to protect babies' brains, whether at term with the risk of brain injury or in the preterm infant?
Thank you. That's a really important question that is under investigation. The reason that we started cooling term-born babies was based on lamb experiments, actually. And interestingly, we've tried cooling longer and deeper and doing all these things. And all of the lamb experiments pointed that this was the optimal timing, the optimal depth. And it's turned out to be the same in human trials. There are currently studies going on in the preterm lamb to see whether we can protect from the risk of brain injury. And I keep telling the incubator makers that they better make their temperatures a little bit more broad for some of our babies. I think it's a very good point, though. We have a lot of difficulty recognising if a baby, when they're born at term, may have suffered a brain injury. Sometimes the babies look a bit stunned or they look not quite right, but we're not sure. And it's even more difficult in the premature baby. So all the difficulties that we have in the term baby are much bigger, and we know that there are certain premature babies that probably have suffered brain injury. We are moving here at the Brigham to create a neurocritical care for the Neonatal Intensive Care Unit, and in that unit we will be monitoring the brains of premature and term babies with not just EEG leads for brain activity, but also with new devices that will be monitoring the oxygen delivery to the brain, and we think that those tools are going to give us better information about whether that baby may be at risk and whether we can offer treatments. New treatments are coming: erythropoietin, melatonin, xenon, newer anticonvulsants, some of the anxiolytic and other medications that Chris has talked about. These, I believe, are going to be additive neuroprotectants.
A lot has changed since I actually trained in the NICU. I was there for a number of months, actually, when I was a resident at Children's, so I know the NICU well. And I remember back then, 15, almost 20 years ago, that they were talking about trying to leave these babies alone. Like, let's not try to disturb them. Let's keep things quiet in the NICU. Let's reduce the number of procedures and blood draws that they need. We're still having that discussion 15 to 20 years from now. And so I guess, Chris, for you, does low-dose morphine work? And if so, how do we know that it's working?
That's the fundamental problem with low-dose morphine is we don't, the studies that are available suggest that it works better than nothing, but it certainly doesn't work as well as we need it to work. And that's why studies of efficacy in the neonatal period is extremely challenging to assess. And we hope we can leverage emerging technologies such as near-infrared spectroscopy, skin conductance monitoring to get a better assessment of just how does the baby look when they get a dose of drug, because that just doesn't work out because babies don't express themselves the same way that adults do. Babies don't talk and tell you what hurts and tell you when they're agitated. So getting feedback from these babies is challenging, but it's something we have to work diligently to do our best. But aside from that, we also have a strong focus on neurodevelopmental outcome and leveraging technologies such as term equivalent MRI that give us the ability to get an idea of long-term neurodevelopmental outcome before long-term happens. So we have a lot of work to do to identify both agents that both work, but also agents that improve outcome. And that's the gap that we're still trying to fill. And I think sometimes accurate assessment is a barrier to those studies, but it can't be because those technologies and those thoughts are going to kind of come together at the same time. So we have to continue to diligently study agents while we also figure out how to best communicate with our babies who can't communicate really clearly with us.
Dr. Sen, going backwards, and the baby is still incubating in the womb. You talked about dietary inflammation. What sorts of foods are we talking about? What sorts of foods should women be avoiding to reduce the risk of inflammation in the body, and what types of foods should they gravitate to that might have some neuroprotective effects?
So I think that a lot of that data during pregnancy is still evolving, but I think in general the recommendations are similar in pregnancy to other parts of the life cycle. So decreasing the amount of saturated fatty acids, increasing the amount of unsaturated fatty acids, which have an relatively anti-inflammatory effect. One of the things that we found is that trans fats seem to have a very strong pro-inflammatory effect during pregnancy. So avoiding foods that contain trans fats. But I think one of the major pieces of information that's still needed is how, in particular during pregnancy, do these foods have specific effects on both maternal health and on fetal health and long-term fetal outcome. And that is something that we have started to look at and are working on designing studies to help specifically understand the impact during pregnancy and on long-term neurodevelopment, how decreasing inflammation can impact those time periods.
And Dr. Ortinau, I think people are probably wondering, is there any impact to MRI on developing fetuses in the womb or once they come out?
Yeah, that's a great question. So MRI is a little bit different than X-ray or CT in that there's no radiation associated with it. So the main thing that we keep track of is actually body temperature. So that's one of the effects that you can get as an elevation in body temperature, and there are actually very stringent regulations on that. So when we're doing studies, newborns, fetuses, whatever, we are very careful about the way that we limit that. There's actually been a white paper that has come out of MGH and Boston Children's discussing the effects of MRI and showing it to be safe in the fetus, particularly even at different field strengths where you're looking at whether it's 1.5 Tesla or 3 Tesla, it's actually safe for them to have MRI. And it's something that we're moving towards using more clinically now too, so that we can help diagnose abnormalities in utero and have a better understanding for counseling families also.
Do we have some questions from the audience?
So, is there any detrimental effect to the baby or to the mom giving, oh, I'm sorry, any detrimental effect to the baby or to the mom giving morphine at any point when you're working with that? Are there side effects? Are there does it last and linger in both the mom or the baby?
So I can speak most accurately to the baby, but yeah, the effects are dramatic, both acutely and long term. Like I said, it was really the take-home point of that one study that I shared was that low-dose morphine is relatively safe for the developing brain. But that's the beginning of a very, very long and convoluted sentence that goes on to say it has acute effects on tolerance of enteral feeds, which is incredibly important to our growing and developing babies. It has effects on respiratory drive. We don't want our babies to be on the ventilator. We want them to breathe on their own because ventilators are damaging to their lungs, and morphine prolongs the duration of mechanical ventilation. Just because we couldn't detect impacts on the large regions of the brain, I didn't share the data that said we looked at more specific subregions of the brain, and at term equivalent, some of those were negatively impacted. So the story gets more negative the longer the sentence goes or the longer the presentation is. So yeah, it's not an agent I'm excited about, and in 7 minutes I didn't characterize that phenomenally, but we definitely need to look at other things because the drugs that we're currently using are not the ticket.
What about neonatal abstinence syndrome? Did I just open up a huge Pandora's box?
What's the session at 11? So we have taken an aggressive approach to quality improvement at neonatal abstinence syndrome in the Brigham, and we'll hopefully take a similar tack to trying to improve the outcomes of those babies. That is a population that is vulnerable. That's a population that's dramatically growing epidemiologically in this region and throughout the country. And the impacts of these drugs in utero are negative. So we have a really burden when these babies come to the Neonatal Intensive Care Unit to do the best thing for that developing brain that we can to get that baby back on track. And traditional therapies, this is my tagline for my life, but traditional therapies don't have the best impact on the developing brain. So we have an obligation to look at alternative therapies and do our best to explore those therapies, make sure that they're safe, that they're effective, and that they optimize our baby's outcome.
Can I also make just a comment that even in narcotic abstinence, it's been shown that nurturing the infant, and certainly for our preterm, we're very interested in the nurturing and the positive reduction in stress that has, whether it's massage, whether it's skin to skin, whether it's other forms of touch or maternal voice, that can reduce. And you often compare, like if you're in the middle of a dark emergency room and somebody's going to come in and do a procedure on you and you don't know when and you don't know what it is and you don't have anybody holding your hand, versus you sitting with the person holding your hand, understanding what's about to happen, when it's going to happen. And so our babies often live in the former, and so finding ways where we can nurture them and reduce. And it's been shown for NAS that if the mother is rooming in with the baby, you can halve the length of stay of the infant because the mother will literally carry that infant 16 hours a day to try and comfort them, and that comforting can really reduce the experience of the distress.
We have 1 more minute. Another pressing question? Yes.
So Chris mentioned 2 sensors that are of interest to him, the galvanic skin response and the optical methods for measuring baby stress. Are there other sensor technologies that would improve your ability to care for these infants?
So heart rate variability has been looked at. It's being established at the moment, I think, as to what measures might be the better measures. It's in its infancy. I can tell you in neonatal intensive care units around the country, people don't even measure the experiences of the infant. They don't even measure whether a parent often has been present, let alone if the baby's had some sort of positive experience associated with that. So we have a long way to go. We've been a very technologically, medically driven profession, and now we're starting to see that some of these impacts on brain development are mediated much more by experience in the environment than by the medical exposures. So we need to move our toolkit to start to capture that, the black box of, we've shown that if a baby doesn't hear meaningful language, if it's in a sensory sort of quiet space, then the language area of the brain won't develop in the neonatal intensive care unit, and those children are about 10 IQ points less on language 2 years after discharge. So they are listening and they need to hear meaningful language, and if they don't hear it, then that will adversely affect brain development. So we've got to capture that experience, and those tools don't exist at the moment.
I want to thank all of our speakers so much for your important work and for telling us all about it, and thank you everybody for coming.